Good morning. My name is Dr. David Orsinelli from The Ohio State University, and I'm going to be speaking today about the echocardiographic assessment of prosthetic valves. These are my disclosures. So I'm going to be speaking about some general principles that I think are applicable to all patients with prosthetic valves, and then speak specifically about features for the assessment of aortic and mitral valve prostheses. So in general, all patients after valve replacement or repair should have a baseline transthoracic study. And this data, especially the gradient, serves as the control for the patient. This should be a comprehensive two-dimensional and Doppler study, and imaging should focus on the valve structure, including leaflet or occluder mobility, looking for any masses, abnormal masses on the valve, things like that. A comprehensive spectral and color Doppler assessment for evaluation of gradients and a search for valve regurgitation should be undertaken. And finally, there should be a comprehensive assessment of left and right ventricular function, the atria, and any concomitant valve disease, as well as an estimation of the RV systolic pressure. How frequently should these patients be followed? Well, I think that all these patients deserve annual clinical evaluation. Guidelines for serial imaging vary depending on the recommendations of different organizations or societies, but everybody agrees that all patients should have a baseline study that can either be done pre-discharge or within the first 6 weeks to 3 months post-surgery or valve repair. Serial follow-up really depends on the valve type, whether it's mechanical or biologic, and any concomitant valve or ventricular pathology. All the organizations agree that there really is no role for routine surveillance with mechanical valves. However, annual surveillance with tissue valves, the guidelines are variable from organization to organization. The 2011 Echo Appropriate Use criteria suggest annual evaluation after 3 years. The European guidelines suggest annual evaluation after 5 years, and the ACC/AHA guidelines recommend annual surveillance after 10 years. Although these guidelines are in a state of flux, and some are suggesting now annual transthoracic imaging beginning 1 year after surgery. And so I think you have to individualize this. The frequency of serial follow-up should also be guided by any other valve lesions or the presence of RV or LV dysfunction that would warrant more frequent follow-up. And certainly an echo should be performed in any patient with new symptoms or changes in their examination that suggest a problem with the valve. All echocardiographers and sonographers, for that matter, need to be familiar with the various surgical valve types, as well as surgical repair techniques and percutaneous replacements and repairs. Understand the expected gradients and patterns of regurgitation. All prosthetic valves are inherently stenotic, and there are published normal ranges based on valve type and valve location. Transvalvular regurgitation is common, and this can be one of two types, either closing volume, which is essentially displacement of blood within the valve as the valve closes and pushes blood back into the receiving chamber, or washing jets, which are jets designed into the valve to prevent thrombus formation. For example, this bileaflet valve here, you can see these normal washing jets through the valve, and this single tilting disc valve, again, a central jet through the center of the valve. So you need to be familiar with these and understand that these are normal. Paravalvular regurgitation is always abnormal. It's more common with TAVR or transcatheter aortic valve replacements, much more common than with surgical valve replacement, and as we will discuss later, can be quite challenging to grade. The Doppler velocity index that I think most of you are familiar with in terms of aortic valves or aortic prosthetic valves can also be used to assess mitral valves, and we'll talk about this in a bit as well. Acoustic shadowing and artifacts can make assessment of valve structure quite challenging, and TEE is often needed, especially in the case of mitral valves or when there are concerns for endocarditis or other valve masses such as thrombus. You need to perform a comprehensive assessment of the valve sewing ring, the frame or stent of the valve, the leaflets or the occluder, look at valve stability, look for any abnormal motion, and a comprehensive hemodynamic and Doppler assessment should be undertaken, looking at the contour of the Doppler signal, the peak velocity and gradient, the mean gradient, the VTI of the valve with continuous wave Doppler, the DVI, which is also referred to as the dimensionless index, the pressure half-time in the case of mitral or tricuspid valves, and a calculation of the effective orifice area using the continuity equation. In addition, a meticulous search for valve regurgitation, noting the presence, location, and severity. I want to speak for a minute about patient prosthesis mismatch. This may be the cause of high gradients with aortic valve and mitral valve replacements and has been associated with adverse outcomes, for example, less LVH regression in the setting of PPM with an aortic valve. You must differentiate this from acquired valve stenosis, and you need to look at and see the anatomy of the valve, assess the valve leaflet and occluder motion, look for any obstructing masses, and I think importantly, compare the gradients with the baseline data that you had from their initial study or with prior serial follow-up studies, or if you don't have that data, with published normal values. In the case of an aortic valve, patient prosthesis mismatch is defined as a valve area indexed to body surface area of less than 0.85 centimeters squared per meter squared, and for the mitral valve, less than 1.2 centimeters squared per meter squared. I also want to speak briefly about pressure recovery. This is described mostly with aortic valves and may be due to hemodynamic factors either downstream from the valve or within the valve. It's less common with tissue valves, mostly seen with small aortas, but is quite common with bileaflet mechanical valves. And the principle is that in the cath lab or with catheter-based gradients, you're measuring the pressure proximal and relatively distal to the valve and measuring that gradient. But within the valve, you may get a pressure drop, as shown on this bioprosthetic valve or on this bileaflet valve, where there are actually two sources of pressure drop, one through the central orifice and one through the lateral orifice. And the Doppler signal, the Doppler gradient picks up this maximum gradient, but the catheter-based gradient picks up the net gradient. And this is a reason for the overestimation of the peak gradients with Doppler versus a catheter-derived gradient. So something to be aware of. Finally, it's important to note that echo is really essential in the evaluation of any patient with suspected prosthetic valve complications. Some complications common to both biologic and mechanical valves include endocarditis, and this can include valve dehiscence, paravalvular regurgitation, valve stenosis, pannus formation, patient prosthesis mismatch, or hemolysis that can be due to paravalvular leaks, leaflet tears, or mechanical destruction of red cells by the mechanical valve itself. Complications more common with mechanical valves include valve thrombosis or thromboembolism. Mechanical failure is quite rare. On the other hand, with biologic valves, structural valve degeneration is relatively common and certainly more common than mechanical failure of a mechanical prosthetic valve. Valve thrombosis or thromboembolism is relatively rare, but recent data from the TAVR literature suggests that it may be more common than previously thought. So it's something to keep in mind when you have patients with tissue valves. So I now want to switch gears and talk specifically about the aortic valve and aortic valve prostheses. The Doppler evaluation should include a comprehensive evaluation of the peak velocity and gradient, the mean gradient, the contour of the jet velocity, and a measurement or calculation of the acceleration time, the DVI, the EOA, and note the presence, location, and severity of any regurgitation, as well as pay attention to left ventricular size, function, and LVH. Some general numbers to keep in mind for normal values are a peak velocity less than 3, a mean gradient less than 20, a DVI greater than 0.3, an effective orifice area of greater than 1.2, and a triangular early peaking jet with an acceleration time of less than 80 milliseconds. If, on the other hand, you have a jet velocity greater than 4, a mean gradient greater than 35, a low dimensionless index or effective orifice area, a prolonged acceleration time with a rounded, very symmetrically contoured jet velocity, that suggests significant aortic valve stenosis. It's important when you're calculating the continuity equation valve area that the LVOT diameter used in that calculation should be measured below the valve sewing ring, and that you should not use the valve size from the manufacturer to use in the continuity equation. The Doppler velocity index for the aortic valve is calculated as the VTI of the LVOT divided by the VTI of the aortic valve. The acceleration time is measured, as you can see in this image, from the onset of flow to the peak velocity. Normal, again, is less than 80 milliseconds. And the effective orifice area should be calculated using the continuity equation as shown on the screen. When you have a patient with an elevated velocity or gradient. You really need to take an integrative approach using all of this previously discussed data, as well as the appearance of the valve, and at times TEE, fluoroscopy, or CT may be useful. And I think this algorithm shown on the slide is quite helpful in evaluating these patients. So if you have a peak jet velocity greater than 3, look at the DVI and the jet contour and the acceleration time, and you can work your way through this algorithm to try to determine what the potential cause of the elevated gradient or velocity is. And I refer to this frequently when I'm reading echoes on patients with prosthetic valves. Valve regurgitation in aortic prosthetic valves can be quite challenging to assess and grade. For surgical valves, you want to look at the circumferential extent of any paravalvular leaks. Mild is considered less than 10%, severe greater than 20%. And there are several parameters that we can look at, including what the valve looks like, what the LV looks like, qualitative or semi-quantitative Doppler parameters such as the jet width in the case of central jets, the CW jet density, the pressure half time of the jet, the LVOT flow versus the pulmonary valve flow with pulse wave Doppler, and look for diastolic flow reversal in the descending aorta using pulse wave Doppler. And also you can calculate quantitative parameters such as the regurgitant volume and the regurgitant fraction. I want to spend a minute talking about TAVR. The TAVR gradients tend to be lower than surgical aortic valve replacement gradients. Again, the LVOT diameter and velocity should be measured on the LV side of the valve, not within the valve. Paravalvular leaks are more common than with surgical valves and should be graded according to the VARC-2 criteria, which are shown on this table. And for mild aortic regurgitation paravalvular leaks, the circumferential extent should be less than 10%, for severe greater than 30%, so a little bit different than with surgical valves. You can also look for diastolic flow reversal or calculate quantitative parameters, again, such as regurgitant volume and regurgitant fraction. You also need to be aware of the phenomenon of valve leaflet thrombosis or hypoattenuated leaflet thickening, something that has been described in perhaps 4 or 5% of all TAVR patients, and the exact clinical implications of this remain to be determined. In terms of paravalvular regurgitation, as I stated earlier, it's more common than with surgical valves, and you really need to take an integrative approach using parameters similar to what we use for surgical valves. But again, quantification is often challenging because many times there are multiple color jets. These jets are often irregular or eccentric. Shadowing from the frame or stent of the valve can cause you to miss jets, and so it's important to sweep through the valve and look at the valve in multiple windows. For example, sometimes with transthoracic echo, you miss these posterior jets, but you may pick them up in an apical 5 chamber or apical 3 chamber, and knowing this diagram, knowing these locations, you can then go back and try to find these jets in a peristernal short axis view. And I use this diagram a great deal with our sonographers to teach them how to seek out these jets. You want to look at the jet width, the number of jets, the vena contracta, and again, the circumferential extent. A vena contracta width greater than 6 millimeters for any of these jets really is fairly specific for severe aortic regurgitation. And here are just some examples of paravalvular leaks post-TAVR, starting with a self-expanding valve with no AR in the top left, a balloon expandable valve with mild AR, a self-expanding valve with moderate paravalvular leak, and then a self-expanding valve with severe aortic regurgitation. Now we're going to switch gears and talk briefly about the mitral valve assessment. And it's important to note that TEE is frequently needed to assess valve structure and the presence, severity, and location of mitral regurgitation due to acoustic shadowing that can obscure the left atrium and cause you to miss color jets into the left atrium. It's important to note that gradients across the mitral valve are influenced by heart rate, and so the heart rate at which you obtain the Doppler gradient information should be mentioned in your report. And in atrial fibrillation, which is quite common with these patients, it's important to average multiple beats, preferably 5 to 10 consecutive beats. The peak E velocity is really a screen for valve dysfunction, both obstruction and regurgitation, but may be abnormal in high flow states, tachycardia, or with small valves. In mechanical valves, you may see a peak E velocity up to even 2.4 meters per second, and biologic valves up to 2.7 meters per second. It's important to note that you should not use the pressure half-time formula to calculate valve area, so you should use the continuity equation because the pressure half-time formula is not valid in the setting of prosthetic mitral valves. And to calculate the effective orifice area using the continuity equation, you need to know the stroke volume, and that's derived from the LVOT stroke volume, similar to what you use to calculate an aortic valve area. And this assumes there's no significant aortic or mitral regurgitation. If the index valve area is less than 1.2 centimeters squared per meter squared, consider patient prosthesis mismatch. And to calculate a Doppler velocity index for the mitral valve, it's simply the VTI of the mitral valve divided by the VTI of the LVOT, and normal is less than 2.2. So if all the parameters are normal, if the peak velocity is less than 1.9, the mean gradient is less than 5, the VTI is less than 2, the EOA is greater than 2, and the pressure half-time is less than 130, valve dysfunction is quite rare. On the other hand, if most of the above parameters are abnormal, valve dysfunction is quite likely, and this may be obstruction or regurgitation, and in that case, the pressure half-time may help differentiate the two. A short pressure half-time suggests abnormal regurgitation, whereas a long pressure half-time suggests valve obstruction. In terms of regurgitation, again, this may be suggested by a high E velocity gradient or abnormally high DVI, and TE is usually required due to acoustic shadowing, as shown in this patient who has a mechanical mitral valve. And on the transthoracic study, you really don't see any mitral regurgitation, but on the TE, you see the normal washing jets in this bileaflet valve, as well as this paravalvular leak. So TE frequently needs to be employed in these patients. And again, when you're thinking about findings that suggest significant prosthetic MR, you're looking for an elevated peak velocity, an elevated DVI, a high gradient, evidence of pulmonary hypertension, as well as evidence that the stroke volume derived by 2D or 3D imaging is more than the systemic stroke volume derived from Doppler. So again, multiple parameters to look at, and you really need to take an integrative approach to this assessment. Many of these parameters are really challenging to assess with prosthetic valves, and again, TE, including a 3D TE assessment, is frequently needed. I'm going to speak briefly about percutaneous mitral valve repair and replacement. There are many techniques under investigation. The only technique that's currently approved by the FDA is the edge-to-edge repair using the MitraClip system. Assessing residual MR post-clip does present some challenges. These studies or these procedures are always done with transesophageal echo guidance, and in the procedure room, in the procedure lab, it's very important to demonstrate a reduction in MR severity or improvement in valve hemodynamics following clip deployment. And some findings that suggest improvement in MR include a reduction in color jet findings such as a smaller jet area or vena contracta, improvement in the pulmonary vein flow pattern, increased LVOT stroke volume, a fall in ejection fraction, or new spontaneous contrast in the left atrium. The clip itself frequently distorts mitral valve anatomy in the flow convergence zone, and frequently there are multiple jets seen. And for these reasons, the PISA methodology to quantitate mitral regurgitation is not recommended. Transthoracic imaging after clip placement is often hampered by shadowing. You should still perform a comprehensive color Doppler and spectral Doppler examination, including a gradient assessment and evaluation of pulmonary veins. But at times you do need to go to TEE to look for evidence of mitral regurgitation post-clip due to shadowing from the clip itself. I'm going to spend a minute talking about tricuspid valves. We really have much less data available to us. The gradients are influenced by both heart rate and respiration. Some general parameters to keep in mind are peak velocity greater than 1.7, a mean gradient greater than 6, or a pressure half-time greater than or equal to 230 milliseconds, all suggest valve stenosis. For prosthetic pulmonary valves, these are most commonly encountered in patients with congenital heart disease, and virtually all of these valves are biologic valves, either xenografts or homografts, and you really look at parameters similar to what you look at for native pulmonary valves. Significant pulmonary regurgitation is suggested by a wide color Doppler signal or a dense spectral Doppler signal with a steep deceleration time and early termination of diastolic flow. Stenosis can be suggested by thickened or immobile leaflets, a peak velocity greater than 3 meters per second or greater than 2 meters per second for homographs, and a mean gradient of greater than 15 for homographs or 20 millimeters of mercury for xenografts. So in summary, the echo assessment of prosthetic valves does present us with some unique challenges. It takes a comprehensive imaging and Doppler assessment to fully evaluate these valves. An integrative approach using all the available echo data and the clinical picture is really required to fully assess these patients. A baseline echo is essential in the subsequent evaluation of these patients, and this assessment, especially of the gradient and valve area, really serves as the control for an individual patient. Guidelines as to the frequency of subsequent or surveillance imaging varies by different societies, but certainly any patient with new or changing symptoms or exam findings warrant a repeat study. And I thank you for your attention.